Raul, will you start the webinar? Okay.
Okay, and then I start the webinar. Yeah, recording and both started.
Awesome. All right, greetings everyone, and welcome to the National Institute on Aging Common Data Elements webinar. My name is Dr. Karen Onyanaho, and I'm the advisor for genomic data sharing with the National Institute on Aging in the Division of Neuroscience. Just a few housekeeping notes before we get started. Our audience is muted. We also have in-meeting chat that's been disabled. However, our Q&A window is enabled to solicit your questions, which will be a part of our Q&A segment a little bit later. Today, cart captioning is being provided by Ms. Adrena Atkins. And so we'll go ahead and get started. I am very pleased to welcome you to our first of many monthly webinars as part of our Common Data Elements speaker series from April to December 2024, featuring a dynamic lineup of speakers who will highlight best practices, standards, and applications that optimize the usage of data resources, as well as effective data management and enhanced data analyses. Our speaker series is designed to allow the NIA community to connect with Alzheimer's disease and Alzheimer's disease-related dementia and aging research while facilitating discussions about resulting research findings and other information as it relates to common data elements, better known as CDEs. So this morning, we are so delighted to have Dr. Michelle Shardell as our featured speaker for today's webinar titled Data Harmonization in Research on Epidemiology of Aging. Dr. Shardell will discuss the use of CDEs to harmonize data for the epidemiology of aging research, including highlights about CDE best practices for harmonizing measures and different approaches to harmonization in order to conduct pooled data analyses. Dr. Shardell is a professor at the Institute for Genome Sciences and Department of Epidemiology and Public Health at the University of Maryland School of Medicine. Dr. Shardell is a biostatistician, and her interdisciplinary biostatistics in aging research includes refining structural models to assess the relationship of blood biomarkers with aging-related outcomes, developing novel statistical methods to handle survival bias and unmeasured confounding in studies of older adults, adapting machine learning methods in pooled cohort projects, and using machine learning methods to identify clinically meaningful thresholds for chronic health conditions. Dr. Shardell received her PhD in biostatistics from Johns Hopkins University, Bloomberg School of Public Health. Please help me welcome Dr. Shardell. Dr. Shardell, without further ado, I'll now turn it over to you for today's lecture. Thank you.
Thank you so much, Karen, and thank you so much all for joining us, particularly if you're in the greater Baltimore, Washington area. It's beautiful outside, so we appreciate you spending this late morning with us. I'm just going to go ahead and get into it after that really nice introduction. And get my slides to advance. I have nothing to disclose. And a very brief outline, I was toying with what the title of this talk should be, and my alternative title was Data Harmonization in the Real World. So I'll review a general framework for how I think about data harmonization. Next, sometimes it's easier to think of things in terms of an example, so I'll go through 2 case studies. And then after reviewing the 2 case studies, I'll come back and circle back to our framework to talk about some takeaways and conclusions. So data harmonization in the real world. Sometimes it's helpful to start from a broad framework. That way we can think about how different types of problems can fit into a framework and how methods can apply to these different examples. So the general framework is that we have multiple, what I'm referring to as cohorts in quotes, because we'll see sometimes when we're thinking of things as cohorts, it's not traditionally what we would think of as a cohort. These are what we want to harmonize, and not all cohorts administer the same measures that we would like to harmonize. So the idea here is, how can we use validation data to facilitate data harmonization? And these validation data are going to be what we refer to as our common data elements. So these are the measures that are in common across our cohorts. Broadly speaking, I think of data harmonization as a combination of a missing data problem as well as a measurement error and misclassification problem. And we'll see how this framework can be applied to a couple of case studies. So here's more of a visual representation of this framework. Let's say, as an example, we have two cohorts. One I'm going to call cohort A, the other I'm going to call cohort B. And let's say cohort A, they administered measure 1. So maybe for the construct that we want to study, this is our preferred or most accessible measure that we would like to perform our study around. However, cohort B used a different measure to tap into that construct. We could think of this as two different measures of depressive symptoms, maybe two different measures of cognition, but for whatever reason, we prefer measure A over measure B, but we would like to perform our study combining data from both cohort A and cohort B. So in this framework, we have participants who are in cohort A had been administered measure 1. Participants in cohort B had been administered measure 2. But ideally, we have some participants in at least one of the cohorts. In this case, it's cohort B, were administered both measure 1 and measure 2. So these participants are what I'm referring to as our validation data, because they have both measures available to them. And so with respect to these participants, measure A or measure 1 and measure 2 are common across these participants. And therefore, we have our measures as common data elements across these two cohorts. And so this exemplifies how data harmonization is a missing data problem. Those cells that don't have a check in them are missing data, as well as a measurement error or a misclassification problem. So if we're referring to measure 1 as maybe our gold standard or preferred measure, measure 2 might be thought of as an error-prone or potentially misclassified version of the measure that we would like. So how do we deal with this situation? Well, as any card-carrying biostatistician would say, our short answer would be, it depends. It depends on our research problem, in other words, our study goals. It depends on the level of availability of our common data elements. For example, are validation data available in the cohorts that we would like to harmonize? It also depends on the plausibility of some assumptions that need to be made with respect to what kind of common data element or validation data are available, which can sound all kinds of abstract. So let's make this more concrete by thinking of this in terms of our two case studies. So the first case study that we'll talk about is one where on its face doesn't really seem like a traditional example of data harmonization. And that's a case of handling studies that have recruited proxy respondents. Case study 2 is going to be one where that probably fits into our preconceived notion of what we mean by harmonizing data. And that's a case where we are having the goal of harmonizing data from 5 separate cohorts. And I'm not using cohorts in quotes because it is traditionally what we would think of as cohorts. So first I'll talk about case study 1, and I'll introduce you to this problem of dealing with proxy respondents. So in this particular case study, this was motivated by a cohort study that was carried out as part of the Baltimore HIP studies. And so this was a large research program that was carried out at the University of Maryland School of Medicine. And that included 502 older adults who were hospitalized for hip fracture. And in this case, we want to look at whether or not their perceived mobility 2 months post hip fracture is associated with 2 years survival after adjusting for some covariates. So within this framework, we have some patients who are willing and able to provide a self-report with respect to their perceived mobility. And so we frame this as our gold standard measure because we were interested specifically in their perceived mobility. However, some of our participants were not able to provide self-reports. And so in order to preserve the generalizability of this patient cohort, we recruited some proxy respondents who were essentially relatives or informal caregivers. And so they provided an assessment of the study participants, what they would think was their perceived mobility 2 months post-fracture. And so we frame this as our error-prone, potentially biased, potentially misclassified version of the gold standard that we want to measure. So going back to that introductory framework, we could think of the patients as being a cohort in quotes, the proxies as being a cohort in quotes, the gold standard patient self-report as being our preferred measure, and the error-prone proxy report as being sort of the other measure that we're trying to utilize here. So we see that we have a certain number of participants who were able to provide the self-report for whom a proxy was not recruited. We have a certain number of participants who were unable to provide a self-report. And so those were the ones where we had our proxy report, and we could see that missing data is where there's no check mark. However, for a certain subset of patients, they were able to provide their own self-report, but we also recruited a proxy. So again, we see among the participants who were able to provide a self-report, that represented about 365, among whom 77.8% said that their mobility was independent. The ones who were not able to provide a self-report and required a proxy, about 44.5% said that the patient was independent. So what do we do in this situation where we have the patient self-reports, we have the proxy reports, and we do have access to some validation data? Well, let's think about this. One solution would be just to analyze the patient self-reports only. However, as said before, we recruited the proxies to preserve generalizability. And so if we ignore the participants who required the proxy reports, this could lead to some type of selection bias. Another option would be to do what I'm referring to as single or deterministic imputation of the missing patient self-reports with the proxy reports. So simply just substituting in the proxy reports as if they were patient self-reports. The challenge with that is that this could lead to a type of misclassification error or bias. And this is generally concerning, particularly if we're talking about proxies who don't have much opportunity to observe the patient. And so these tend to be the most error prone. So we opted for what we're referring to as solution number 3, which is multiple imputation, or another type of stochastic imputation, where we can leverage the proxy reports and use those to impute the missing patient self-reports. So in order to carry out this imputation and leverage the validation data, we use machine learning for model flexibility. And because the individuals for whom we have validation data, that also represents a type of selected non-generalizable population, because these are the type of participants who were willing and able to provide a self-report. We're going to perform a type of sensitivity analysis around the ways in which the participants who are part of our validation data subgroup may differ from the patients who are not willing or able to provide their own self-reports. So to talk a little bit more methodologically, we opted to use a particular type of machine learning approach. And I mentioned that this was a multiple or stochastic imputation. And so what makes this stochastic is that we have a few randomization elements. One randomization element is to step 1, carry out a bootstrap sample, estimate the distribution of proxy reports, and use a machine learning algorithm referred to as boosted classification and regression trees. And we opted for this type of approach because it was an ensemble-based approach that tends to perform better than a single classification and regression tree and other variations of ensembles of classification and regression trees. So then we estimated an analogous distribution using the patient self-reports among those who had proxy reports. So this is in our validation data. And from this bootstrap sample and these estimations, we imputed a missing patient self-report from the estimated patient self-reported distribution. Then we used just complete patient self-reported data to estimate propensity scores and performed a complete data analysis. And because we wanted to account for the fact that we had potential confounding and we wanted a standardized approach, we used inverse probability weighting in our estimate. And because this is multiple imputation, we carried out this procedure multiple times. So looking at what the results were, because we carried out this approach, also embedded in it is a sensitivity analysis. Remember, our option 1 was to ignore our proxy data and only analyze our patient data. So when we looked at days alive, comparing those whose self-perception was mobile versus not mobile, the difference in mean days alive was 44 days. But for that to be valid, we would have to assume that there was no selection bias, which doesn't seem plausible. When we used our single or deterministic imputation, where we simply substituted the missing patient information with the proxy information, in that case, we have to make the assumption that there's no misclassification error or bias. And when we did that, our mean difference differed quite a bit. We had 62 days versus the 44 days under a different set of assumptions. So we could see how our estimates here can be quite sensitive to the assumptions that we're making. So what about the multiple imputation approach, where we can look at various assumptions and see to what extent varying these assumptions impact our results? So when we carried our multiple imputation, where we assume that proxies are better at being sensitive than specific, in other words, they're more accurate when a patient is able to be independently mobile than they are when a patient is not independently mobile, we received a mean difference that was somewhere in the middle between our two assumptions. When we assumed that the proxies are more specific than they are sensitive, we received results that were more like what happens when we just eliminate the proxy data altogether. Now, when we assume that proxies have almost negligible misclassification, but not zero misclassification, and we account for the fact that these are in fact estimates, they're not deterministically true, we also receive results that were somewhere in between the no selection bias assumption and the no misclassification error bias assumption. So we see that our overall take-home message in this case study was fairly robust to the type assumptions that we were making, and that those who self-reported independent mobility at 2 months post hip fracture had more days alive over the course of 2 years than those that did not. But the estimates themselves varied drastically depending on what assumptions we made. So given the approach that we used, we could probably think of ways that we can refine this and update this with new technologies. So what are some possible extensions we could have carried out? So we used a particular type of machine learning algorithm. We used boosted CART, but we could have very much used a different kind of ML or AI method. We could have used superlearner, which is also an ensemble-based approach, but rather than just an ensemble of classification and regression trees, it could have been an ensemble of many different types of learners. We could have implemented deep learning. And if this is a topic that is of great interest to you, there's going to be a follow-up webinar on May 3rd, so I advise you to check that one out. What about using some metadata from the proxy respondents in an ML or AI imputation model? So for example, I was referring to some of the past research that indicated that different types of proxies might have different levels of accuracy with respect to reporting on a patient's perceived mobility. So we could use some information like that from the proxy, such as their relationship to the patient or their living arrangement with the patient, to help enable this kind of imputation. And so the idea here is that there's plausibly higher sensitivity and specificity if the proxy respondent lives with the patient. The other approach would have been, in addition to the way we use validation data, we could have used it as more of an anchor for sensitivity analysis. So the idea here is to look at the level of misclassification or estimate the degree of sensitivity and specificity, specifically using our validation data, start from there and look at assumptions. If you increase the level of sensitivity and specificity and decrease the level of sensitivity and specificity relative to that anchor. But as mentioned before, we need to be aware in this context because the patients in the validation data set are not generalizable to the patients who need proxies, which is why we have proxies in the first place with these kinds of studies. So what are some best practices that we can learn from these kinds of examples? So with respect to data collection, one best practice is to be aware of making sure that we ask the right questions to the right people. So if we can recruit proxy respondents who have that level of knowledge about the patient, that is ideal. Making sure that when we frame our questions to the proxies, we frame them with harmonization in mind. So framing questions to the proxy, trying to get at what kind of information we would have wanted to be able to collect from the patient if we were able to. So that's another way of saying word the questions to minimize misclassification. The value of the harmonization framework allows us to see that that's our North Star when we frame our questions. So the idea here is to recruit proxies who are likely to provide accurate responses and to be able to generate validation data, even if it's in a small subset, if that's possible. With respect to data analysis, we want to see how robust our conclusions are. So performing sensitivity analyses, particularly when that requires us to make assumptions that aren't necessarily testable with the data that we have in mind. And so one quick way to do that is to see if you were to make some opposite extreme assumptions within the range of plausibility, see if those produce the same take-home message or conclusion, and then report those results. So if we are carrying out a study where we are recruiting proxy respondents, report that that is so, and report the descriptive statistics of the proxy data. Okay, so moving on to our second case study. Again, this is one that probably looks a lot more like what you would have in mind when we talk about harmonizing data. So in this case, our goal here is to harmonize data from Black and white older adults across 5 cohorts. There is the age, gene, environment study based in Iceland, Reykjavik. Then there's the health, aging, and body composition study, the Invecchieri and Chianti, or aging in Chianti, or otherwise known as just in Chianti data set, the osteoporotic fractures in men data set, and the study of osteoporotic fractures. And we could see that we have 3 different countries represented, different sample sizes, different composition with respect to race, ethnicity, and sex, although all have approximately similar mean age. So our research question in this project was, what sex-specific threshold of circulating vitamin D concentrations best discriminated between those who experience incident slow gait speed at a follow-up time approximately 3 years after the vitamin D assessment versus no incident slow gait speed. So just to get a sense of how common this was, among the women, we had 18% who experienced incident slow gait. Among men, we had about 12% who experienced incident slow gait. And this was defined as approximately 0.8 meters per second. And so the type of measures that we were interested in harmonizing, there was usual gait speed. And the challenge here is that some of the cohorts used a 4-meter course, others used a 6-meter course. For respect to vitamin D, there were 3 different approaches used to measure vitamin D. So there was the challenge of harmonizing across those 3 measures. We also wanted to do a comprehensive adjustment for prevalent health conditions at baseline. The challenges with some of the disease algorithms that tend to be thought of as best practices, not all the components were shared across all the cohorts. And there were other measures that we wanted to adjust for, such as cognition, depressive symptoms, where we had analogous kinds of challenges. So what was the solution that we used? So our North Star for determining how to harmonize these data was that we knew going in that these 5 cohorts were likely to be very heterogeneous. And wanting to pull these data together, we wanted to remove as much of the between cohort heterogeneity as possible that was just due to different measures. We didn't mind retaining just some of the inherent population differences because we thought of this as a strength that enhanced generalizability, but we wanted to remove the kind of heterogeneity that was due to just using different measures. So when we're talking about usual gate speed, I mentioned that the challenge is that this was measured on different lengths of a course, 4 meters or 6 meters. Some of them use 6 meters, some of them use 4 meters. We opted to use more of a singular deterministic imputation because we really didn't have access to what we would refer to as internal validation data, but there had been some external validation data that were generated to support these kinds of gate speed pooled harmonization data projects. And so what we used is we leveraged this external validation data to carry out sort of a conversion equation approach to harmonizing to a 4-meter course. What about the case of the circulating vitamin D or 25-OHD measures? So again, we had 3 different approaches. We referred to as radio immunoassay as our gold standard. And the rationale for that is that a lot of the reporting that was going on at the time in terms of recommendations was based on radio immunoassay. So we used multiple steps that leveraged a combination of internal and external validation data. So in step 1, we had access to some internal validation data in AGES, which used both the liaison approach and also a liquid chromatometry tandem mass spec type of approach. So we were able to harmonize between those 2 measures within the AGES study. For step 2, we leveraged some of the published conversion equations that enabled us to convert from the LC tandem mass spec to radio immunoassay. So that allowed us to put all of them within the frame of the radio immunoassay. There was also an additional type of effort that was carried out using external data in ANPAINS that enabled adjustment over time based on what was known as the vitamin D standards program. So we leveraged that to also harmonize the radio immunoassay because these cohorts were assessed at different time periods. So lastly, what about some of the disease algorithms? So as an example, I'm letting you know what we did with the case of hypertension, where best case scenario, we could have used a combination of medications, self-report, measured systolic blood pressure, and measured diastolic blood pressure. The challenge here is that not all of these elements were measured in all of the cohorts. And so ideally, we would have been able to fill that in, but we also wanted to account for the fact that we wanted this to be accessible as well as accurate. And we referred to our North Star approach as removing as much between cohort heterogeneity that was due to the measures, do that as much as possible. So we only used the systolic blood pressure in our hypertension assessment. I know I said diastolic there, but we ended up just using systolic, medications, and self-report. So for other measures, they were part of the same framework as the gate speed, where there were probably 2 different measures, and we wanted to have one reflect our gold standard and the other that we wanted to harmonize from. So one example of this would have been cognition. There is going to be a webinar in December specifically on cognition. We used, again, more of a deterministic approach because that wasn't the main metric that we were prioritizing here. We were prioritizing the gate speed and the vitamin D in particular. All the other approaches, we wanted to keep it as accessible as possible so that this would have been a doable workflow for folks who would want to replicate. So some additional methods, in this case, when we were doing our discrimination for slow gate speed, We did that using a classification and regression tree approach, using superlearner as a tool for standardization to control for covariates with internal cross-validation. And we combine our results using a two-stage random effects meta-analysis. So looking at the results of this, if we look on the left, those are the results for women, and on the right are the results for men. If we look at the top, those are the results and what we're referring to as our training data set, which was a sex stratified random sample of 2/3 of our data. And then on the bottom, that was our validation data set, which was the remaining 1/3 from that random allocation into training versus validation. What was interesting when we used our superlearner standardized card analysis, we found a threshold of 24 nanograms per milliliters for vitamin D for women. And then for men, this was 21 nanograms per milliliters. And what was exciting is that for those of you who are familiar with what was happening in vitamin D at the research at that time, the debate was between 20 nanograms per milliliter versus 30 nanograms per milliliter. So to find results that were somehow in the middle was really exciting. And when we looked at our training data set, we did find that those whose vitamin D was below the threshold, they had a higher relative risk. They had a higher risk of slow gait compared to those who were above the threshold. And this was statistically significant. When we looked at our validation data set, our estimates were consistent with that. Our results were not statistically significant, however, but it's important to bear in mind that our validation data set had half the sample size as our training data set as well. So what are some possible extensions that we can do within this example? One would have been a multiple or stochastic imputation analogous to what we did with our proxy data. When I thought about this as an option for carrying out this analysis, I wanted to speak with some colleagues to see how this would have been received, given how much attention vitamin D was receiving at the time. And the response I got was, wait a minute, that means that one of your cohorts could be completely made of just made up data that you're analyzing. So I took that concern to heart when trying to make final decisions on how to harmonize these data. For disease algorithms, there are some more advanced approaches using item response theory methods, and what's been known in the psychosocial literature is integrative data analysis. This is often also used to integrate cognitive assessments when those measurement scales for cognition provide information about the individual questions as well. We could have used more modern approaches to covariate standardization or meta-analysis using different kind of weighting approaches, different kind of algorithms for estimating those propensity scores that we used for weighting. And so we could have used, for example, deep learning or meta-regression approaches for meta-analysis. There's a whole host of ways that we can extend our approach. So what did we learn about best practices for data collection, analysis, and reporting from this case study? So for data collection is to, when there's composite measures that are part of a cohort, make sure that we collect and provide the individual components of those composite measures to facilitate data harmonization and to facilitate integrative data analysis. When we do collect data, anticipate that one of the objectives would be to use this within the context of harmonization, ideally validation data as well. With respect to data analysis is to leverage the internal and external validation data, but be aware of what modeling assumptions were made. So for example, when we're using these external conversion equations, I had to make the assumption that that conversion that worked well in that external data also worked well in my internal data as well. Using scientific background knowledge can help here. Next would be a type of sensitivity analysis. One of the limitations of the approach that we took, particularly when dealing with the disease algorithms, was that we only used the components that were shared across all of the all of the different cohorts. And so this could have led to some residual confounding or residual misclassification because of those diseases. And so having an alternative approach that is less sensitive to those assumptions to validate is also helpful. With respect to reporting is to comprehensively report all of the methods and algorithms that were used for harmonization, and also what kind of software modules were used to carry out the harmonization and the assumptions that are made within the context of harmonization. So what are some takeaways from this? The one takeaway, we saw that we used very different methods in our 2 case studies, is that there's no one size fits all. Oftentimes, the appropriate approach depends on what are the resources that are available to you. Do you have access to internal validation data? Do you need to rely on external validation data? How clear is it whether or not the assumptions are plausible that generated the external validation data transporting to your own data set? Another type of resource to bear in mind is time and the study objectives, because we are making trade-offs with respect to the complexity of the results that we're using and then how much time they take. Also, one of the goals in our second case study was to develop a workflow that would have been accessible to other folks to use if they wanted to do the same kind of approach that we were using, which was to utilize cohort or observational data to help facilitate designing better randomized trials. And so we wanted to have an approach that people would actually use. With respect to harmonization data, remember the framework, which is that it's a missing data problem as well as a misclassification or measurement error problem. And so this can help inform whether we use a more multiple or stochastic type of imputation versus a singular, which was deterministic, at least in the example that I provided, type of imputation to make available to folks. With respect to primary data collection, again, for those of you who are in the field, plan for harmonization. I think one of the challenges is, should you collect common data elements to harmonize with the existing data, or should you use the most up-to-date measures and anticipate that the future data collection efforts will use those measures? That can be challenging because, again, there's only going to be a limited amount of resources available for you to try to make those common data elements actually common. Validation data can be helpful because that way there can be what is framed as a gold standard measure for the objectives of the data being currently collected. But a small validation data subset can be used for that harmonization to serve as a bridge for all the data sets, whether there's the older legacy data sets, also the data sets that may be coming aboard as well. So none of this work is possible by just one person. It takes a village. And so I'd like to acknowledge my collaborators, as well as some of my funding that helped facilitated some of these approaches. Also, just all of the background work that went into collecting the data from the cohorts that I used in these studies. And if you're anything like me, when you attend a talk, your favorite part is to look at the references so that you can see what to read up on more. So I will leave you with this and thank you for your time, and I'm happy to take any questions.
Wow, thank you, Dr. Shardell, for such a wonderfully insightful and thought-provoking lecture, especially with you sharing, best practices for data harmonization, as well as effective approaches to consider for data collection. You also talked about integrative data analyses that would work well. I also really appreciate you sharing insight about, effective primary data collection efforts while addressing challenges such as limited, resources that are used, but then considering validation data being one effective method to resolve that issue. So at this time, we are now going to turn to our Q&A segment because we want to solicit questions from our audience to Dr. Shardell. So at this time, we ask that you, if you have not done so already, and you'd like to ask any questions, please use the Q&A window to populate your questions for Dr. Shardell. So I'll go ahead and start. One thing I wanted to ask you, Dr. Shardell, is how can machine learning and artificial intelligence be combined with your framework to carry out data harmonization?
Yeah, that's a great question, particularly given that machine learning and artificial intelligence are such hot topic these days. And so this is, again, an area where I see that central framework being very helpful, thinking of the data harmonization problem as being this combination of a missing data problem and a misclassification / measurement error problem. And so for one, I think a lot of the advanced machine learning and AI approaches can be very useful for imputing the missing data. And so the idea here is that the better these algorithms get, the more accurate our imputations can be. So that can help us resolve some of that missing data problem, as well as help us get closer to the true value of the missing data. So reduce some of the misclassification measurement error issue as well. And so I see those as advanced approaches that fit into the framework.
Excellent. Yeah, thank you so much for sharing that, considering how those algorithms could help yield greater research results. I greatly appreciate your insight there. And so we do have an audience question or a few of them that came in, and I'll punt them to you. So one of our audience members is asking, when deciding which variables to harmonize, can you share an effective approach for creating an initial plan for validation data and perhaps any clear objectives about what one might want to consider to achieve that?
That is a great question. I think it first starts off with asking the question, what is it that you're trying to optimize here? So if your objective, for example, is to optimize confounder control, that may lead to slightly different approaches than, for example, what we used in the vitamin D study, where our objective, first and foremost, was to reduce the heterogeneity that was just simply due to the different measurement approaches. So as an example, with our hypertension example, we just said, okay, one of the cohorts did not measure diastolic blood pressure, so we just won't use it in our algorithm to harmonize, to make sure we're just using the same algorithm for all of our cohorts. Whereas if hypertension was really central to our research hypothesis, we would have certainly prioritized the accuracy of classifying hypertension status. So we could have, for example, used a different kind of imputation approach to impute what was that missing element in the one missing cohort, so that we could use a more comprehensive type of algorithm to try to fill in and use all of the data available to try to classify hypertension status as well.
Yeah, thank you for your response there. It actually is a great segue to another question from our audience. Considering modern missing data methods, which generally start from, for example, missing completely at random, in the cohorts that you are trying to harmonize, do you have assumptions about the missingness that you can share?
Right. So when we were addressing the missing data problem, particularly in the vitamin D study as an example, one of the ones that we were primarily concerned about was, a missing follow-up study, the missing follow-up assessment for gait speed. We also were concerned about missing covariates, but to a lesser extent. And so we did carry out a different kind of inverse probability weighting to account for both missing data with respect to just, general attrition, folks not returning for their follow-up gait speed assessment, as well as the survival bias problem as well. So we relied on some of our observed covariates to do that. And some other work I've carried out, we also carried out a sensitivity analysis to get a sense of, okay, among those who are missing, can we quantify to what extent that missing value it could have impacted the probability of missingness using a sensitivity analysis approach, given that that's another example where you have untestable assumptions. So using a sensitivity analysis type of approach can be used analogous to what we did in the proxy data example, where there were just some assumptions that were not testable from the data that we had available. And so we used a sensitivity analysis across different assumptions to see if our findings were robust to our different assumptions.
Excellent. I appreciate that too, because like you mentioned for case study number 2, that deterministic approach that was used to measure cognition, I think is a great way to at least share what effective approaches one might want to consider, at least in this case, when determining slow gait speed. You mentioned, considering even the missingness when it comes to quantifying what those missing values are to take into account the missingness. So I appreciate the audience member for asking that question.
It's a great
And so
question.
definitely, we do have a lot more time. I want to maybe go to another question pull from our audience who's asking, how can machine learning and artificial intelligence be combined with your framework to carry out data harmonization, which you talked about a little bit earlier, but if you'd like to delve a little bit deeper into that, that'd be great.
Right. And so, again, since we're thinking of this as a missing data problem, then if we're trying to impute that missing data so that our downstream analysis can leverage some of those advanced complete data approaches, certainly machine learning and advanced AI types of approaches can help us hone in on more flexible models to better impute some of those missing data. One of the challenges, particularly if you're carrying out a multiple imputation kind of approach, is there's going to be some between imputation variability. And so the better your algorithm is at imputing, then we can hopefully reduce some of that between imputation variability as well to get more reliable as well as more accurate results.
Excellent. And we have a sort of a multi-question coming from one of our audience members. And I'll ask the first part is, can you tell us more about how common data elements fit into the world of data harmonization? And then the second part of this question is it that using common data elements streamlines assessments such that data do not need to be harmonized, or vice versa?
So I see the common data elements as helping to facilitate the harmonization. So if there are elements that are used across cohorts, then those are more easily harmonized because we're using the same measures across the cohorts. So that's the ideal situation. We also want to bear in mind that standards change in terms of what is the best measure for a construct of interest. So part of the tension might be the burden on the participant and the resources available to collect multiple data elements that tap into a construct of interest. So for example, there's multiple ways to measure depressive symptoms, there's multiple ways to measure cognition, and it just may not be feasible to get all the different measures, even though we want to be able to harmonize our data to multiple different cohorts that themselves have different measures. So the idea of having that small validation data set within your cohort is that it can offer as a bridge to perhaps some of the older legacy cohorts that used an older version of a measure, and also some of the newer cohorts where maybe folks are still in the field and the best practices have changed regarding what is the best measure. So being able to harmonize with the legacy data sets as well as with the new data sets, that becomes a lot easier if there are data elements in common with both of those kinds of data sets. And you have at least one data set that has multiple measures, even if it's within a subset of participants, that can form that bridge. It's almost like a Rosetta Stone that can be used to translate and enable data harmonization.
Yeah, I really appreciate you sharing that. It made me think as well when you were going over case study number 2, how one might want to think about some of the self-reported data across different cohorts, which brought me to think about you mentioning, perceived mobility was provided as self-reported data from research participants or the patients in case study 1 as the preferred measure to preserve generalizability. You also talked about, collecting assessment of the study participants in terms of their perceived mobility. When a proxy was required, would really help with mitigating error or data that may be prone to error or bias. I do appreciate you mentioning earlier, which coincides with what you're sharing now, how one solution is to actually analyze the patient-reported data, as well as the data from the proxies, to make sure that there is uniformity in what the proxy is actually relaying from the patient or from the research participant, to mitigate, again, any potential for error or bias. You also talked about another solution should be considering multiple imputation or stochastic approaches to take into account, the missing patient self-reported data, which could be leveraged by machine learning. And so I appreciate that. We do have another question from our audience. I believe this is relevant to the second case study. They're asking, for the vitamin D data, have you looked at differences if you do not assume a gold standard, for example, assuming errors in both, as it sounds like there was a debate on positive determination, or at least a cutoff there?
Yeah, so part of the reason why we picked one assay as, I wouldn't necessarily want to refer to as our gold standard in the universe of research and assessment of vitamin D, but rather a preferred measure, so that we can compare with some of the previous reporting that had been done on vitamin D assessments. Is we wanted to make sure that if folks read the previous reporting and then read our study, that they were comparing apples to apples and know that we were referring to the same underlying approach for measuring vitamin D. So we did not carry out the rest of the analysis without using the conversion equations. That would be also a very reasonable type of sensitivity analysis to perform, to see, what if we didn't do that? Would we have gotten similar results, regardless of the way vitamin D was measured across the different cohorts? Would we have gotten similar cutoffs, and would we have gotten similar downstream results with respect to how vitamin D relates to incident gate speed?
Thank you for that. I have one question, relevant to case study number one. You mentioned that best practices include accurate data collection. That is, being aware not just that the right questions are being asked, but that they're being asked by the right people. For example, those who were recruited as proxy respondents who, with respect to their role, have a level of knowledge about the patient or about the research participant, as well as, having questions that are actually framed with data harmonization in mind. And you also touched on the importance of recruiting proxies who are able to provide accurate responses, as well as considering how those responses will yield robust conclusions, with considerations about, as you mentioned, performing sensitivity analyses, which in part does take into account, the assumptions that may not necessarily be testable. I was wondering, what other approaches could be considered to account for potential error or bias when it comes to reported proxy data?
Yeah, so there's been some really interesting research published on, the role of proxies, depending on the reason why proxy respondents are recruited. Sometimes they're referred to as external raters. So, for example, in our first study, we framed the patient's perceived mobility as the gold standard, because that we saw their perception as being part of our research question. But if instead we were more interested in just their mobility, as a latent construct, we would have had to bear in mind, for example, that the patient's perceptions may not always match objective data. The proxies assessments may not always match objective data, but these are two pieces of information that can help us measure an otherwise latent construct that, ideally we would also include some performance data as well. We could include a lot of different pieces of information to measure that construct. And so in that case, if we're only recruiting proxies when the patients are not able to self-report, that would have been more of a mismatch between our study design and the way we're conceptualizing mobility and the things that we're trying to measure using data from proxies. We would have wanted to recruit proxies as much as possible, so we could have this fuller picture of the participants' mobility in this case. So it's bearing in mind, again, what your research question is and why the proxies are being collected and what you're even framing as your gold standard to help mitigate some of that bias, and then making sure that your study design it fits in logically with your research question and your objectives.
Yeah, excellent. I really appreciate that approach. It kind of coincides with a thought that I had earlier, when you described, how to yield accurate data, right? By not ignoring the proxy data and not only relying on what was collected, by the patient or by the participant who's a part of the cohort. We talked about, taking into account the difference in the means days alive. You mentioned in one respect, it was approximately about 44 from the perspective of the patient, and then with the proxy about 62 days, and that how, somewhere in the middle with considerations for no selection assumption led to robust findings, I believe, for one of the studies. You also talked about the importance of the patient's perception, which may not always match the objectives or the data objectives, and which is why assessment on what proxies are being recruited is really a critical component to the design of the study to yield those robust results. So I greatly appreciate you describing that, as well as, describing, which ties into one of the questions that we received from the audience, how machine learning was used as a validation method to extend the research findings. I believe it was for case study number 1, while also considering, again, that relationship between the patient and the proxy, and even mentioning, the living arrangement, which in most cases we may not think about when it comes to that proxy participant relationship. And so I think we have maybe room for one more question before we move to closing. You also talked about other, considerations that include disease algorithms and covariate standardization and even meta-analyses for case study number 2. Are there any other individual components that should be considered for data harmonization or even integrative analyses that would work well?
Right. Yeah. So that's a multi-part question. So I always saw it as a trade-off of, using the most advanced methods and then using what may be the most accessible methods. So in particular for that second case study, one of our objectives was to try to find ways in which we can use observational data that can help with designing clinical trials. And it's because vitamin D was such a hot topic at this time, and it was becoming very difficult to do randomized trials on this topic because it had received so much attention in the lay press. So a lot of people were taking vitamin D supplements. And so it was hard to recruit individuals with low levels of vitamin D. And so our thinking was, if we can come up with a nice accessible workflow that can bear in mind both harmonization and heterogeneity and all those types of considerations, then, for the next, supplement or micronutrient that's starting to get this level of attention, we can implement our workflow before it becomes difficult to do the randomized trials. And then this could help inform how to do the randomized trials. So we saw this as something that was a bit more generalizable. Whereas if we would have done the most advanced stochastic multiple imputation method for all of the measures that we carried out, that may have been much less accessible to the rest of the audience who might want to use an analogous kind of workflow, or whatever becomes the next hot supplement that starts showing up in the lay literature.
Wonderful, Dr. Shardell. First of all, thank you so much for your insightful and very valuable feedback, and thanks to our audience members for your thought-provoking questions. I would like to at this time end our Q&A segment. For any questions that we may not have gotten to, we'll make sure that we address via email to our registered attendees. But I do want to thank our esteemed speaker again, Dr. Shardell, for being a part of this really wonderful lecture. And we know that because of her expertise and her engagement and insight at today's webinar, it is highly valuable in advancing the field of CDEs and data harmonization, but also ensuring scientific progress and supporting our mission here at the National Institute on Aging to support and conduct genetic, biological, clinical, behavioral, social, and economic research on aging. Now, before we close, we do have 2 poll questions that we would like to ask the audience. Raul will pull those up in a minute. If you could, before you leave, give us some feedback. We'd love to know, what aspect of today's lecture was most interesting, and also what topics would you like to see in the future? As stated earlier, we do have a lot more webinars taking place this month, beginning May through December, and we would, be so delighted if we knew that some of these questions could help inform future webinars. So with that, I wanted to, thank you all for your time today, attending today's lecture with Dr. Shardell. Again, I mentioned earlier that we will respond to any questions that we did not get a chance to ask during today's lecture. Thank you all for your time. Thank you, Dr. Shardell. It was wonderful to have this lecture with you.
Thank you so much for having me, and thank you so much for the organizers and the attendees as well.
Thank you so much, everyone.
Thank you, and have a great afternoon.
Take care.
Bye, everyone.
Bye-bye.